Well, hi, I'm Chet Whitley here, the homeboy, so to speak, and I want to thank the organizers for doing this, the sponsors for making it happen, certainly for AbbVie to making it a global meeting, which is really quite remarkable. Uh, can I see my first slide when it's convenient here? This building actually has become somewhat historic in the field of lysosomal diseases such as the glycoproteinoses. Do I need to stand back a little bit here? Um, and if you think about 1988 and go back to the other end of this very floor here, this building used to be the Radisson Hotel. And it was on the University of Minnesota campus as it is now. And might need some manual help here or do something differently. Advance the slides. Abby, can you just advance the slide, please? So I started here my graduate training in the laboratory of Dr. Robert Desnick, who has again come back to be part of this important meeting. And he may remember back May 20th, 1988, when the very first lysosomal disease meeting, actually it was the first International Congress on Mucopolysaccharidosis and related diseases, was organized here. Next slide. Let me go back up. You see down at the bottom, there's several international supporters of the meeting then. Of course, there was absolutely no commercial support, no industry support back at that time. There basically were no therapies. We were experimenting with hematopoietic stem cell transplant, what we call bone marrow transplant back then. And that was my particular interest. On the right bottom, I want to note that the ML4 Foundation was supportive. I'm not sure if that even exists anymore. There's a lot of activity in the field, but I think this group of glycoproteinoses is very greatly underrepresented. And I'll explain that here in a minute or so as we go forward. So think about that. I did pull up the program from that meeting, the 1988 program. And it's amazing to me who attended, what the subjects were, how much has changed, but also some things that have been the same and continued on. For example, at this meeting, John Wolf, who's here today, was at that meeting. Bob Desnick, I believe, was there. Elizabeth Neufeld, Marito of Marito-Lemay syndrome, Harold Shea, Hank Shea, who had moved to the University of Pennsylvania after going to medical school here, spoke at that meeting. John Hopwood from Australia spoke at that meeting about discovering the glycosphingolipids and eventually the cloning of many of the genes. Did I say Liz Neufeld was here? Joe Munzer was here. It was really a dramatic group that had not been talking about mucopolysaccharidoses together. And that was the interesting fact about that meeting, that people started talking again together and working on things a little bit more collaboratively. It was quite remarkable. I can't see here on the left, but I believe that's a natural history study for one of the mucolipidoses, actually. Maybe somebody's a little bit closer to the for sialic acidosis, right? So people had even thought about the very, very important issue of natural history studies. And I hope we talk about that a lot this weekend. Over to the right, you'll also see another discussion of a very small study. And this was a spartoglycosaminuri, I believe. And there again, a Puerto Rican study. I'm sorry, I don't have a big Puerto Rican study of 3 families. And as Dr. Patterson pointed out, that's what we're up against for natural history studies. So what do you think? A company that wants to make $1 million or 100 times that on a drug, are they going to go after a natural history study, a disease for which they can find 3 patients? This is what we're up against. Next slide, if you will. So click again, please. There we go. So here's someone out of the UK who published on 250 patients with all of the mucopolysaccharidoses combined. Click again, please. I'll try this. I want to again emphasize the concept of natural history studies. It's absolutely vital now, if one wants to develop a product, a biologic, a disease treatment, to know a natural history study. We'll talk about that a little bit more. But it was going on even back then. We did not have the internet. We did not have email. We had correspondence by paper. but still people were doing these things. This particular abstract talks about going to the homes in Hunter and Hurler syndrome patients to get access to the patients to gather that information. It was very hands-on, very manual back in those days, but people were trying to develop an understanding. And this abstract also concludes that what they're finding out by doing natural history studies, actually seeing and examining patients in a prospective way, led to results that did not fit the literature, the published literature at that time. There's an important lesson there, isn't it? Prospective, going out, finding all the patients, not just taking the words of the medical literature, the collaborations. Now, at the end of this meeting, there was one other attendee who had participated, and we were very optimistic here at Minnesota. We were doing bone marrow transplants for Hurler syndrome and other lysosomal diseases. We were finding some efficacy. By the way, that does not have to go through FDA review because it's a procedure. It's not a drug. So we could start doing things that maybe didn't require the same kind of industry investment. But Victor McCusick, the father of medical genetics, got up at the end of that meeting and talked about where we're going to be. Those of us who were young bucks at that point in time thought gene therapy was just around the corner. But frankly, I was quite deflated when he said, this is great progress. I hope probably, we'll have gene therapy for Hurler syndrome in 30 years. And he was about right on. So I think we have to think about that trajectory, although things are accelerating dramatically now. So let's talk about that a little bit. Yeah. Abby, go ahead. So next slide, please. Time for a battery change. There we go. So we're giving Victor McCusick some attention there. Well, what are we doing when we're doing a natural history study? We're creating a fertile field for somebody with a lot more energy and money to come in and design a treatment and test it, a clinical trial. In most clinical trials for a lot of other diseases, you have 2 or 3 limbs, right? You have one limb that gets the new experimental treatment and another group that get the placebo. That's not very kind. It's not very welcomed by patients. I've been in a double-blind clinical trial myself. I wish it was for allergies, but it was for something else. In any case, back then we were starting to understand what needed to be done. It was scientifically obvious. You have to pick some measures, outcome measures, that tell you at the end of the day, did our treatment work? In the case of bone marrow transplant, there's a 20% risk of death if one has a HLA-matched identical sibling. It was a 50% risk of death if you had used any sort of other mismatch, a 50% risk just going through the bone marrow transplant procedure, and you didn't really know if it worked. Yeah, we knew we could put hematopoietic stem cells from a sibling donor with normal enzyme into a patient, and it would circulate through the blood. Maybe it would get to the liver in some places. It would certainly not get across the blood-brain barrier, right? So patients that undertook participation in those studies back then were a very special and desperate group of patients. But we learned a great deal. And I want to review some of what we did back then because it's a good entree into what we now have to recreate in our own way. I'm going to emphasize the point that I think the glycoproteinosis diseases have been left behind. But it's your opportunity to pick up the gauntlet and bring them forward. And I hope that's what we can do this weekend. Create the natural history studies, which will measure outcome measures, which will be useful for interesting clinical trials by people that have the resources to do that. So if we go back then, you can see this was published in 1986, just before that 1988 meeting here in this hotel. The second one's followed on, but the first article looked at clinical phenotype, or the efficacy that we hope to change on the left, and also the biomarkers, which the FDA looks at as not satisfactory for getting a drug approved, but very supportive. So any clinical trial that you look at, if you go to clinicaltrials.gov, if you look at the label of a drug, it always articulates, maybe it's somewhat hidden, but you're seeing 2 different things. You're seeing evidence of clinical efficacy. This is what the FDA requires, clinical efficacy, something that you as a parent or a patient will see right in front of you. My child has changed. I'm doing much better. I can walk further. I can think better. On the other hand, that's sometimes not enough. you might want to have some blood study or some blood test or urine test that tells you how it's working, how well it's working to gauge dose and prove that what you're seeing clinically is not in your imagination. It's not a placebo effect because you went through a bone marrow transplant. There's measurable biochemical and chemical changes, maybe even bone changes. You have to see histopathologically. Other biomarkers that tell you what you think you're doing can be proven out from the clinical phenotype, what the patient sees and feels, what the physician sees and feels, but also underlying pathobiology, biochemistry that fits with that. So on the left is Kelly Berger, the first child in the United States with Hurler syndrome to undergo hematopoietic stem cell transplant right here. It wasn't easy for her. In fact, she started losing engraftment so she came back for a second bone marrow transplant. But ultimately, she survived. You see before transplant, the features of that condition, the big liver and spleen, stiff hands, we call it claw hand back then. We can see frontal bossing of her head. Her face was changed. And we see under her bone marrow or peripheral blood evidence of those granules. But those are the clinical phenotype, what the person observes about the disease. On the right hand is showing the first 3 transplants we did. The first being Kelly, patient number 1, received a homozygous donor marrow. The second patient, her brother was a heterozygous, making only 50% of the normal hydrogenase. So she got half as much, a dose effect, if you will. And the third, the same thing. All those children survived transplant, and we had an opportunity to measure both the change in clinical phenotype, what mattered to the parents, and the child's survival. But we also had to back it up with outcome measures, things that we present to the FDA to say not only do we have a clinical outcome, we have the underpinning biochemical, other changes that show that it's working as planned. Things that would let you determine dose. It doesn't make a difference. In this case, if a patient has a homozygous normal bone marrow or a heterozygous carrier bone marrow as a source of enzyme, which would only be 50%. So in each of these cases, our mission this weekend and in the years going forward, if we want to treat glycoproteinosis, is to keep our eye on these 2 things. If we want a drug or a biologic approved by the FDA will want to see a clinical measurable outcome, something of value to the patient, but also the underpinning biomarkers that measure why it's happening that way. Does it fit with our hypothesis? What are those things we can measure scientifically, do standard deviations and statistical analysis on, to prove on a large group of patients it's really happening? So think about that. Abby, do your magic. Next slide, please. So here are 2 other measures of what happened to those patients. So these are, you'll see above them, increased blood enzyme level in the first 3 patients. They all start at 0 enzyme, but after they're engrafted, their level goes up either to the homozygous donor. That's Kelly. She had I'm sorry, that was the middle one who had a normal homozygous donor. The other 2 had heterozygous donors. So it kind of fits with what we expect. The donors had half as much enzyme, resulting in half as much enzyme in the patient. And the one who had a homozygous 100% enzyme donor, that was much higher. On the right, you see another metabolic indicator, urine glycosaminoglycan, the bad stuff, the material that's accumulating in the body and causing the disease. Well, it starts at very, very high, 5 to 10-fold above normal. Once we get the bone marrow engrafted, enzyme is going through the blood to the rest of the organs, and we go down to near normal levels. Notice it's not normal, but it's near normal. It's a huge difference from where they started. Next slide. So those 2 biomarkers are one thing we have to acquire. At the same time, we're making other assessments. How does the patient feel? Are they performing any better? So next slide, please. So here's what the clinical effect is. There's Kelly, and marked in magic marker is where her liver and spleen used to be when we examined it just by feeling it. And on the right, I think it was 12 months later. After a year, her liver and spleen had shrunk down to a more or less normal size. And on the right, we make that very quantifiable. We measure by CT scan through serial sections of the liver and spleen what the volume was of her spleen and her liver. And frankly, I think we were the first ones to do that for any storage disease here. We didn't have MRIs back then. The child got a little radiation. We paid the technicians in pizzas at night to draw circles on the computer around the surface area of the liver spleen slice, and then added them all up. That's how those numbers we came up with. Next slide. That's now available as a regular clinical measurement. So in the long run, 20 years later, psychometrists like Julie Isengart, who's going to be here, like Elsa Shapiro, accumulate all of our IQ data, if you will, or developmental quotient data for Hurler children before they were transplanted. Remember, 100 on the vertical scale is average. Everybody here has IQ about 120, 130. You're very, very smart people if you look at the whole population. But on average, anybody off the street, not on the university campus, but everybody else, has an average IQ of maybe around 100. If you're 2 standard deviations above the mean, that's 130. If you're 2 standard deviations below the mean on like a developmental quotient or IQ of 70, you're just barely able to live independently. So it's very important to know how the disease progressed if there was no treatment. And if you look at the equation in the upper right-hand corner, binomial equation, right? So the slope of the line is 20, and that indicates that for every month for which treatment was delayed, for every year, there's 20 IQ points lost. Hurler's syndrome on average was injuring the brain with a 1.6 developmental quotient number per month, 20 IQ per month per year. So by the time a child's 1 year of age, they've lost 20 IQ points. By the time they've reached 2 years of age, they've lost 40 IQ points, and they're never going to recover that. That kind of damage is permanent. Thus, that is motivated. What we do now in Minnesota and several other states in the union, we diagnose babies at birth so that transplant or any other treatment can start immediately within the first week or 2 of life when we diagnose the baby. So that's very important. That is a natural history study. We happen to have many of those patients go on to bone marrow transplants, so their IQ, we learned later on, was stabilized. And that was the efficacy that allowed us or encouraged us to continue bone marrow transplants, which is what we do today with augmented bone marrow transplant with gene therapy. So next slide. So here's one more illustration. This is what Dr. Jarnes did with me about 10 years ago. This was a young gentleman. He stands out or stands low with Martolomé syndrome. He's there in his high school class after receiving a bone marrow transplant 18 years prior. He was transplanted here for Martolomé syndrome at 2 years of age, actually 18 months. Now, we thought it was a great therapy. He had normal enzyme floating around his blood. He could talk, normal airway problems. Really, he was doing fine. Do you think he thought that was a good clinical outcome? Was that a good impact on his clinical phenotype? Does he feel like he was treated well or cured? Well, there's a pretty visible difference, isn't there? So at 18 months of age, the regular, very successful, uncomplicated bone marrow transplant still left him of short stature. It means that we can't get all the sites perfectly. We did create a really wonderful lifestyle for him. So he came up to the clinic one day, and Dr. Jarnes and I were sitting there with him. Can we go next slide, please? And he said, Dr. Whitley, I hear there's this new thing coming out called enzyme replacement therapy. And I've only got 5 minutes. We'll have to go fast. So to summarize, this is published. You can see at this time, his urine GAG level was about 9 times normal. Next slide. We started giving him we gave him 1 shot of Naglazyme enzyme replacement therapy. It's not CME, so I can use the name. Can you quickly go through the next slides? You can see his urine started the first 3 dots before getting additional IV drug. We gave the galsulfatase then, and look what happened over the next 10 days. So the peripheral IV enzyme added efficacy, according to this, over the next 10 days. It brought the urine GAG down even more. It brought it down below the dotted line from slightly above normal into normal levels. So you can see 1 shot of enzyme had a remarkable impact on that biomarker. So Taylor comes back 2 years later, and we say, Taylor, did getting that extra enzyme make a difference for you? He says, I don't really think so. I don't feel any different. Then his mom said, wait a second, Taylor. We were at Disney World a couple of years ago. You were in a wheelchair within 6 minutes of being in the lot. Lately, just a couple of months ago, we went to Disney World, and you walked the whole day. So his joint laxity, his joint motility had dramatically improved. And Elizabeth Braunland looked at his heart by echo, very sophisticated studies, and he was essentially recovering lost cardiac function, diminishment of valves. So next slide. We're going to go really quickly. This is really important stuff. So ears up, guys. Next slide. Here at the first, next slide, please. International Symposium, Mucopolysaccharidoses. Again, next slide. Click again. Natural history studies are important. Next slide. We have to define what the disease is. And Victor McCusick, the father of medical genetics, defined that for us all. Next slide. Many of you have heard about OMIM, but you probably don't know what it is, do you? Victor published volumes trying to categorize every single disease. He used to go around to meetings with a 3x5 card and write down, oh, that poster, like the posters in back here, that's describing a new disease. He would accumulate them on 3x5 cards, take them back to Johns Hopkins in the library, eventually published books on it. And then along came the internet. And so now you have access to all of his information, plus more that's been added to it. So when we talk about the glycoproteinoses, the place to start, and I hope each speaker will reflect on this, there's not just one mucopolysaccharidosis type 2 or Jules Leroy disease. By the way, Jules spent time here in Minneapolis in Bob Disnick's lab doing a fellowship many, many years ago. So look at OMIM to define the disease. Maybe that needs correction. As part of the problem, the surveys we're going to look at are still complicated. An infant with ML2 does not have the same clinical phenotype as an adult with ML2 or ML3, but the same genes are there. So we have to consider that. Next slide. So we're making history again today, like we did in 1988. Next slide. Next slide. I want to invite you to the 18th, back up one more if you can, World Symposium. That meeting in 1888 set families on a course for putting this meeting on again every 2 or 3 years. But this is a different group. But if you have this meeting, and I'm going to challenge you, don't just do this every 2 or 3 years. Do it every year. The speed at which you do a meeting, getting people together like this, is the speed by which you will make progress. Next slide. Next slide. So that's why we do this meeting every year. Next slide. It's like clockwork. This should put us in line, possibly for a grant. It's not going to be cheap, but $1 million a year from NIH would be dramatic. Next slide. You can see Bob. So let me move on here. I want to say that Bob Disnick had one of those 15-year grants to chart the natural history study and develop therapies for porphyrias. I was the PI of another 15-year grant through that mechanism that supported 152 publications doing natural history studies. Dr. Jarnis's part on that got 4 different companies interested in her diseases, the gangliosidosis. Next slide. So this is what we need to look at. Back up one more slide. I'm sorry. Thank you, Abby. So what are we looking at? By the end of the meeting, we'll look at measurements on the left, which are outcome measures. They're not, I have abdominal distress. They're not, I have organ dysfunction. They're not things like, I don't feel like getting up today. I'm not going to school. But what they are is something we can measure and put in front of the FDA. And these are various diseases that have gone through FDA reviews under clinical trials. And on the right hand, it lists where they were primary indicators, the key one to which FDA looks at to grant the company approval or not. But secondary biomarkers, mostly, they look to the backup. So at this time, I'm off the stage, and I think it's time for the next speaker. I thought we were supposed to go till 9 o'clock, but is someone else coming on board now? Okay, I'm a little confused now. I'm getting a signal we're done. I thought this was supposed to go sometime. So I'll keep talking until somebody tells me to stop where it's 9 o'clock.
Yes, we have some more time. Right now I have, after the outcome measures, patient voice, and our next session for alpha-mannosidosis starts at 9 o'clock.
Great. So let's spend about some time. This was our mission. How are we going to do this? Well, perhaps some of you have heard of a white paper. If any of you have your computers on, put in a white paper. It's generally some sort of scholarly or expert opinion on something. And if this group could get together in this meeting and write a white paper and talk about our mission going forward, which I'm going to say to you should be conducting natural history studies. And further in that white paper, it'd be important to know what do we know and what don't we know about these conditions. we have to have a starting point. So that's what a white paper can do. It can describe where are we now. You're going to see an occasional outcome measure based study like Dr. Isengard's cognitive assessments. That is a measurable clinical outcome that the FDA will look at. You can also think about where do you want to go? Well, hey, we've got a treatment for one of the conditions, and there's others very interested in it. Are they going to have to do double-blind placebo studies with some of our patients? How many are volunteering their child or themselves to be in a double-blind procedure for a new drug? Wouldn't it be great if they didn't have to? So we can create that placebo group because there is no therapy for mucolipidosis 2 and 3 now. There is no satisfactory treatment for fucosidosis. There is no satisfactory treatment for any of these conditions, or the therapies that are being tried now are still very much in their infancy. We could do better. We could do better. But we don't know what better is, and we can't tell the FDA what better is unless we know where we're starting from, natural history study, and then look at what outcome measures the FDA would respect to give a new drug approval. So I want to hear what the patient voice says for each of these conditions. And then Dr. Jarnes and Dr. Patterson will help us walk through the idea. How do you translate what the patient feels or what they need? What's that unmet medical need? There's a group we can write about and say, these would be corresponding measurable outcomes. Some of them will be clinical phenotype. Am I more mobile? Can I walk for 6 minutes farther now after treatment than I could walk in 6 minutes a year ago before the treatment? Is my accumulation of sialic acid or excretion in the urine reduced now compared to what it was before I got the treatment? What's the before and the after that's quantifiable? You can do statistics on 5 or 10 or 100 patients and bring that data to the FDA so that your child, or maybe you, do not have to be part of a double-blind placebo control. And furthermore, and even equally important, once a company like Chiesi, like anybody else who has the money to invest in new treatment, now they have a target. They're willing to invest tens, if not hundreds of millions of dollars of investor money in the existence of their company on a tangible target. You've defined it in the white paper. And then maybe you get an NIH grant and you start doing the natural history study over 5 or 10 years. You're developing that data. And as the data becomes published, becomes more visible, you've done something. And you've created therapies for your children or for yourself that you as a patient advocate cannot do alone, but you can make it happen. So think about these. Maybe we should just open up for discussion as you're thinking about what questions you might want to put on the table. My goal is to have everybody here who's a writer, a speaker, to submit a paragraph to me. And we've already started that white paper article. Not good enough to show you. It's kind of an outline right now. But I want it done 6 weeks from now. That's a lot of fast writing. But if you stay with me and write what you know into a brief 5 or 10 page white paper, we know that this meeting happened. There'll be notes from it. And furthermore, it will define what we know about these diseases now and what we don't know. It will define what therapies exist in the outcomes or what experimental studies could be done or are in progress. It'll define not only the patient voice, what I feel, what I'm not able to do because I have one of these conditions. It'll also define how that is translated into an FDA measurable or evaluable outcome measure. That's your job. Package that up in 6 weeks into 5 or 10 pages, and I will help you, but we're having to move quickly. It'll go to peer review in the February issue of Molecular Genetics and Metabolism. It'll be there for everyone to see. And furthermore, it might be the beginning of writing an NIH grant, which, by the way, is due at the NIH October 16th. Everybody I know here as a scientist is saying, like, you kidding me, man? That ain't going to happen. Well, I can tell you we've already started it. We're talking with people about Mayo with other diseases that could be partners in this, and reaching out to other sites around the country, around the U.S., to help gather the data for these conditions as well as some others to put together that grant application. So are you up for it? I saw a hand up. I see a couple of hands up. Okay, two people are gonna help me. It'll be a small author list, but it could be bigger. Maybe there are people around the globe on the internet here somewhere, thanks to Abby, that can kick in. So for all of you people who are listening and have not filled out the ISMRD patient voice survey, go online and fill it in. We're going to start talking about it now. You're going to see that the patient voice is a mixed audience. Here's another principle that will be very important as we whittle those things down to something useful. Do you have the same unmet need if you're the parent of a baby who's 2 years old with a, let's say, ML 2 or 3? Do you have the same patient need or desire or hurt or problem because your baby doesn't have treatment that somebody who's got the mild form of that, the attenuated form of that ML3 and is gainfully employed at a high-tech job, but still suffering? Do they have the same unmet need? Is the patient voice saying the same thing? Maybe the parents of an infant who's dying will say, no, I want greater longevity for my child. I want to see a Kaplan-Meier life analysis. Dr. Patterson, Dr. Jarnes can take that concern, my baby's not doing so well, they're not going to make it to their next birthday, and translate into something scientific that's measurable in a natural history study. They're going to help translate that patient voice, that complaint, that unmet need into something measurable in a natural history study. So what if your hearing is bad, like mine right now? Hope mine is just allergies, but maybe that's a big complaint for you because you just can't hear very well. And maybe hearing aids are not even adequate. And maybe you wish you never even had a hearing loss. Well, are current therapies addressing that adequately, or could we do better? So the patient says, I can't hear very well. I'm having a hard time even reading lips. Wouldn't it be great if I never had permanent hearing loss, which may even be resistant to cochlear implants, hearing aids, stuff like that? Well, that patient voice is translated into an audiogram, is translated into a bear test, and that becomes a measurable clinical outcome measurement. Just by example here, in our Hurler studies, we went on for about 10 years with Hurler syndrome, acquiring data on what turned out to be 11 patients who were transplanted with Hurler syndrome, 2 of whom passed away. But the remaining 9 had all those wonderful biomarkers, okay? They had urine gags go down. They had enzyme up in the blood. They had a lot of things that were really looking good, like even the shrinking of the liver and spleen. Now, if that was an FDA reviewable drug, would that have been satisfactory? Well, Emil Kakis at BioMarin came along just after that bone marrow transplant era, and he said, I want to make an enzyme, an IV drug for people with MPS I. But he knew the enzyme would not cross the blood-brain barrier, so he got very creative. He said, what can I put in front of the FDA in a clinical trial? What measurable outcomes? And which of those have clinical significance for the patient? So he conducted a trial of what they now call aldurazyme luronidase. And the outcome measures they presented to the FDA was not cognitive studies. It was not IQ measurements, developmental quotients. It was reduced liver and spleen sign, improved cardiac function, and a 6-minute walk. At that time, where we're trying to prevent mental retardation, so to speak, brain damage for babies with Hurler syndrome, he was thinking far ahead. If I can at least get a drug approved for the adults, maybe we can prescribe it, as we sometimes do off-label, to younger patients. And that's exactly what has happened. Get your foot in the door, get a drug approved with an improvement in clinical phenotype and the biomarkers to back it up, decreased urine. You get through FDA approval, you've got a drug. And you define what that population is that you're treating, but then you've got some leverage and you can expand the group of people you're treating, and that's where we are today. So I know people here, Troy Lund in particular, where did I see Dr. Lund? There he is. He's measuring changes in cerebral spinal fluid, glycosaminoglycan, which is different in patients that get ERT versus those that don't. Even if they've had a transplant or not, I want to hear what he has to say about that. I think it's not on your scheduled talk, but I'd love to hear you comment on that.